I've edited this review just a little bit, and when I get done, I'll post this into Canvas so you'll have it. So just starting this chapter 21, definition of a high-quality image is on page 279 in Bushong. We've got a couple of things there. It refers to image quality, or image quality refers to the fidelity with which the anatomy under investigation is rendered on the image receptor. It goes on to say medical images that faithfully reproduces structure and tissue is identified as a high-quality image. So in structure and tissue, what it's referring to there is just sums up spatial resolution, contrast resolution. The tissue is your contrast resolution, the structure is your spatial resolution. The structure is the lines in between the anatomical structures, as opposed to the tissue resolution, or the quality in reproducing the tissues, is can you see the difference between those tissues? Can you see the difference between the lung and the bone, or the lung and the soft tissue? So it's both types. So what we have, the most important characteristics of a high-quality image is we want to be able to see that spatial resolution, and we also want to see the contrast resolution too. We have to be able to visualize both. And the other two are things that we want to limit. We want to limit the noise, and we also want to limit the artifacts. So there are two types of resolution, and we went through those in the last section before the last test. And neither one is really dependent on the other to exist, but in order to have a quality image, you have to have both. Doesn't matter if you have perfect spatial resolution, if you're completely covered up with fog or overexposed, and so you've flooded the image receptor with so much radiation that you can't make it, you can't see the structural lines, then you lose contrast. So you have to have contrast resolution, and you have to have spatial resolution for optimum image. Contrast resolution is just that, it's difference. Contrast is always difference. And it's difference between, in the anatomy, it's the difference between soft tissue, air, different types of soft tissue, fat versus muscle versus internal organs, or soft tissue versus bone. So how you recognize a question that's asking specifically about contrast resolution is contrast is always going to be in the question, or if contrast is not, then it's going to be asking about tissue density differences. So difference or contrast should be in the question. So if contrast is not, and you see words like recorded detail, sharpness of recorded detail, resolution all by itself without contrast being a portion of that, then what you're looking at are things that are controlled with your geometric factors. That is your sharpness of recorded detail, your spatial resolution. So noise, the definition of noise is random fluctuations on the image, and the noise can mess up your at least your visibility and possibly your sharpness of recorded detail. If you have quantum model, it's the recording of the tissue types might not be there, and if it is, then it's going to be covered up with those little speckles that you'll see because of a lack of exposure. So the other type is just all about contrast. If you have an image that's dominated by scatter radiation, then you're going to lose contrast, and you can see that in the difference in patient types. If you have a hypersthenic patient, then that patient's going to create a lot of scatter radiation, and the image that you create is going to come out very gray in appearance, especially in chest x-ray and abdomen and pelvis x-rays. If you have an asthenic patient, then they don't create as much scatter radiation. It's much more black and white, it appears more crisp. So if you've seen, two of those images, and you probably have, you just aren't real sure what, you hadn't put it together yet, maybe. So the higher contrast images of, especially in the abdomen, generally come from asthenic or at least sthenic patients. The real gray, washed out looking ones are generally your hypersthenic patients. Image receptor speed refers to the amount of radiation that is needed to create an image, an adequate image. So a faster image receptor speed needs less radiation, so you can cut back on your technique. Higher speed image receptor systems are more sensitive, so they require less radiation. And our digital imaging is as fast as radiography, if not faster. When we made the switch from screen film radiography to CR, we lost some speed, which caused us to need a higher technique in order to compensate. So we increased our technique, and the patient dose actually went up whenever we went to a CR system. But once we went to a DR system, we were able to cut that radiation exposure back down, even below what we used for screens and films. The drawback to fast image receptor speeds, really more in screen film radiography than what we see in DR, is that because they require less radiation dose to create the same image, theoretically we could have an increase in quantum model. Our image receptors are sensitive enough that quantum model isn't as much of an issue as what you might think it is, and certainly not as much of an issue as what we've stressed in class, but you have to know the information for the registry. The characteristic curve, the H&D curve that we've talked about in class, I'm going to bring this over and we'll take a look at that. Herter and Dreifield curve. Really the only way that this is still applicable is that if you could get into your imaging system and see the different algorithms, then they might have an H&D curve assigned to the different computer algorithms. So the portions that you need to know of are the shoulder, the linear portion is what they're calling it here. You'll see it referred to as straight line portion, and the toe. The toe represents minimal exposure below the threshold where we get good diagnostic quality images. The shoulder represents the area where we've got way too much density, and then the straight line portion represents contrast. So if it represents contrast, it also represents latitude. Remember, contrast and latitude are inverse of each other. I'll talk about that in a minute. In the review, it refers to speed. So with speed, what we've got is whichever one of these curves is most radiosensitive, whichever one is most sensitive around the toe portion. So it's at a specific point. You see base plus fog here, and I'm not going to go into that. That's screen film thing. But if we have an exposure, the exposure axis is horizontal axis and the density axis is vertical axis. But if we have an exposure that gets us to an optical density of 1.0 plus base plus fog, that is the speed point. So whichever one of these two lines, whichever one of these H&D curves got us to 1.0, using the same exposure, got us to 1.0 plus base plus fog, the quickest, would be the faster of the two. And most of the time, even in screens and films, what we had was the fastest screen film combination would also be the highest contrast, which is what you're seeing here. So when we have a vertical curve like this, the straight line portion is very vertical. That means that we've got very high contrast, very low latitude. When it's horizontal, we've got low contrast, high latitude. So traditionally, again, a high-speed film would have high contrast, but we did have high contrast slow speed films that typically we used in mammography. So 1.0 plus base plus fog may be way over here, but once it got to that threshold exposure that took us into the vertical portion of this, it would go almost straight up. So very high contrast, low speed, but most of the time they're synonymous, high speed and high contrast. All right, so what represents speed? That would be the speed point at 1.0 plus base plus fog. What represents contrast? That would be the straight line portion, how vertical it is. The exposure axis is the horizontal axis. The density axis is the vertical axis. Vertical curve means high contrast. Horizontal curve means low contrast. Optical density, as it relates to exposure, it doesn't really that much anymore, but it does still relate to your index number. So high exposure gives us an index number that indicates that we have a high exposure. So some of your systems, your exposure goes up, the index number goes up. Some of your systems, the higher the exposure, the lower the index number. So what we use to control exposure generally is mass. And we can use KVP, but mass is kind of the industry standard. Reciprocity is manipulation of MA and time to maintain the same mass value. So where we use reciprocity, most common place we use reciprocity is if we have a potential problem with motion, be it usually involuntary motion, but if we want to introduce motion, like a breathing technique, we can also use reciprocity. Decrease MA, increase the time, use like a breathing technique. Or the Otnello method, wagging jaws, so to speak. So most of the time, though, we want to increase MA and decrease time. There's one other way that we can control exposure time, and that would be with an increase in KVP. If you had a situation where you wanted to reduce time and you were phototiming without having to come all the way out of the menu on your control panel in order to make that change in MA, then what you could do is increase your KVP. Just increase your KVP, and your photocells are going to shut off sooner, and it should result in a shorter exposure time. That's not reciprocity. That's using the 15% rule. So contrast is always difference, regardless if that's radiographic contrast or subject contrast. Subject contrast would be the difference between bone, soft tissue, bone, air, soft tissue, air, soft tissue of different types. So that's subject contrast. And what the difference in tissue types will give you your radiographic contrast. So radiographic contrast is difference between black and white. So how does subject contrast or subject density relate to radiographic density? As subject density increases, radiographic density decreases. So if you have two tissue types side by side, one with low radiographic density and one with high, then you're going to naturally have high contrast. So now you've got bone, high subject density, next to air in the lungs, low subject density, and that's going to give us high radiographic density where the air is, low radiographic density where the bones are, or the mediastinum. All right, so what tissue types are most dense to least dense? We did that in the last section, so it would go air, fat, muscle, bone, from least to most dense. So the tissue type that creates more photoelectric interactions would be bone. More scatter would be any kind of soft tissue, but especially adipose. What is image contrast? That is difference on the difference between black and white on the image. How do differences in subject density affect radiographic density, subject density affect radiographic contrast? We just did that. how does differential absorption play into the contrast? The higher the differential absorption, bone's going to have higher differential absorption than air. Then the bony structure is going to appear more clear, more white compared to the surrounding structures. So in the digital image, the thing that really controls your contrast, again, is your lookup table, your computer algorithm. So an image that has high contrast would be very black and white. Low contrast would be very gray. Short scale contrast, again, would be black and white, as opposed to long scale contrast would be very gray. High latitude would be very gray. Low latitude would be very black and white. So low latitude is high contrast, and high latitude is low contrast. We just did that. Technical factor used to adjust contrast. Neither one really, but KVP traditionally. Contrast is really not manipulated with technique anymore. It's really a computer algorithm. But patient size can affect it still. So again, if we have an obese patient as opposed to a asthenic patient, the asthenic patient is going to appear with much more subject contrast. I think we've done that to death. Thickness, again, hypersthenic, tissue mass density, effective atomic number. We've talked about all that. I don't know that it's really drawn out well or illustrated well on page 289 is absorption blur. So absorption blur is a thing that affects not just sharpness of recorded detail, but also visibility of recorded detail, because it gives the appearance of a loss of contrast. So if your X-ray beam follows the shape of the object well, like what we talked about in both the spines and the wrists, if we shoot the wrist AP, this would be a conical shaped structure. So not only will we get a sharper image, but let me bring up another image here. So what we've got here is a square object that does not follow the divergence of the central ray like that one did. So with this one, what we have is we've got some differences in tissue thickness that we have to penetrate. So we've got a little bit of what we should have on this image is not really the shaded area, but it should be very dark versus very light. So not only do we have good sharpness for recorded detail, but we've also got good contrast as well. As opposed to on this structure, we have to penetrate a little bit. So this portion, what penetrates through this little edge over here, is going to be slightly darker than what this area over here does, has what it looks like on the image. So what we're going to have is, because this area is higher and further away from the image receptor, we're going to have a loss of sharpness for recorded detail, but at the same time, because we've got to penetrate that, we're going to go from dark to slightly less dark to clear. Then it's going to give us the appearance of a loss of contrast as well. So we've got more gray. We have a longer grayscale. So that's what we refer to as absorption blur. It's not just the loss of sharpness for recorded detail, but also loss of contrast because of the shape of the structure. If we, again, have a round structure, it's going to be even worse because we've got a very thin area that we would have to penetrate, and it continues to get thicker and thicker. So what that's going to do is not only have a loss of sharpness for recorded detail because we have areas that we can't get close to the image receptor, but we've also got a graded scale of contrast going from the thinnest area to the thickest area. Absorption blur. The difference in absorption because of the thickness of the structure, but also because of the change in OID, effectively OID, we're going to lose sharpness of recorded detail, plus we're going to lose some contrast, and that's what absorption blur is. It's caused by the shape of the structure. The shape that is most susceptible to motion blur would also be a round or spherical shaped object. So remember KVP's effect on differential absorption as KVP goes up and differential absorption goes down. As KVP increases, we penetrate more tissues. Doesn't really have an effect on contrast anymore. Doesn't really have an effect on density, but it does have an effect on your index number. So your geometric factors would be your magnification, your distortion, shape distortion, size distortion, and your focal spot blur. So magnification, sometimes referred to as size distortion, and the two things that it does to the image is creates size distortion, but you also lose sharpness of recorded detail. So the role that SID plays is that as we increase SID, we're going to reduce magnification and gain sharpness of recorded detail. So increase SID increases sharpness and reduces magnification. Unfortunately, as we increase SID, we're going to lose image receptor exposure, and how we compensate with that is with mass, with the with the direct square law. We lose exposure according to the inverse square law, and we have to reintroduce it using the square law. As SID decreases, then we're naturally going to get magnification, and we're going to lose sharpness of recorded detail, and we're going to gain exposure. So we would have to adjust. As we decrease SID, we're going to have to decrease our technique. As we increase SID, we'll have to increase technique. So OID also plays a role in our magnification. As we increase OID, we increase magnification and we reduce our sharpness of recorded detail. How we control magnification is with preferably with as low a OID as possible. If we can get our OID as low as possible, we don't have to do anything with our SID. But if we have an increase in OID, how we compensate with that is with an increase in SID. So the two things that we use to control magnification would be SID. Long SID is better for reduction of magnification, and OID. The lower the OID, the better we are. So magnification factor is calculated two different ways: SID over SOD, or image size over object size. Remember that your object size is always going to be smaller than your image size. So magnification is always present. Your image size is always going to be larger than your object size, always. And how we correct for magnification is if we have an increase in OID, we're going to increase SID, compensate for that. So our other types of distortion, we've got elongation and foreshortening, is sometimes called unequal magnification. The things that cause distortion would be image receptor angulation, central ray angulation, or angulation of the body part. So what we want is our central ray and our image receptor to be perpendicular to each other, and we want our anatomy parallel to our image receptor, so also perpendicular to our central ray. How does object thickness affect distortion? Well, it depends on where it is, the object in question. If the object in question is in the middle of the central ray, then object thickness can affect magnification, size distortion. If it's away from the middle of the central ray, then we're going to see some elongation because of the divergence of the central ray, like what we talked about in class on Wednesday of this week. How does object position affect distortion? Again, depends on the context, but the object position generally when you're talking about object position, you're talking about the object or the specific anatomy being at an angle to the to the image receptor. That's going to cause foreshortening. Generally speaking, you get elongation with a increase in angulation of the central ray or an angulation of the image receptor. And you get foreshortening with angulation of the anatomy. So we just really talked about this. Elongation is angulation of the central ray, angulation of the image receptor, and foreshortening would be angulation of the part. Repositioning, all of those would be how you correct for it. So if an object is angled to the central ray or to the image receptor, let's go with image receptor first. If we have an anatomy that's angled to the image receptor, then what you're going to have is foreshortening, unequal magnification. So the size that's closest to the image receptor is going to show the least amount of distortion, size distortion anyway. So this graphic in the textbook is just a little bit confusing. I really kind of wish that he had not put all of the arrows at an angulation. This is really good for demonstrating foreshortening, but in as much as demonstrating elongation, I wish it was more parallel. So the reason this is elongated, even though we've got a angulation between the object, the arrow, and the image receptor where the shadow is projected, is because of the angulation that's coming out of the divergent central ray. This side is also divergent, but it's divergent to make it more parallel to the arrow, which gives us our foreshortening. Another thing that we didn't really talk about in class is this spatial distortion. So let me get to the graphic on that. Is that the one I'm looking for? That is not. Nor is that one. I'm going to put you on pause. Here it is. So spatial distortion, again, this is a little bit tough to look at because you've got a little bit of an optical illusion, but these two objects are the same size. This one looks longer because it's extending out into this baby blue shaded portion. So they're both the same size, but because of the differences in distance, a difference in OID essentially, then object A looks like it's much larger than what object B does. So that's your spatial distortion. So it really, in this context, there's a difference in magnification between two things that are identical in size, but the appearance on the image would be that they are not. So you can have two objects that are positioned at different depths within the patient's body, and they're essentially the same size object, but one is going to appear more magnified than the other. And that can give you a little bit of give the radiologist really a false indication of how big something is. An example of that